Hello, people. This is Dr. Muskaan this side, and let's dive deep into this case and enjoy. Here is 52-year-old male who has came to OPD with chief complaints of shortness of breath, fever, and abdominal discomfort since yesterday. HOPI. Patient was apparently asymptomatic since yesterday when he developed shortness of breath, which was sudden on onset, progressive in nature, from MMRC grade 3 to MMRC grade 4. Means it was progressive in nature. It was associated with whitish and yellow colored sputum. He also complained of abdominal discomfort, which was gradual on onset, dull in nature, and associated with one episode of vomiting. He also complains of fever, which was sudden on onset, aggravated on doing work, and relieved on taking medications. Past history shows no comorbidities. Personal history is vegetarian by diet, sleep habits are adequate, there is no addiction to alcohol, there is addiction to hookah and bidi, one bundle per day since 20 years. Bowel and bladder habits are normal. General examination, decubitus patient is lying comfortably on bed oriented to time, place and person. Vitals of this patient shows tachycardia and tachypnea and mild fever. Okay, now pickle, that is parallel icterus clubbing cyanosis, lymphadenopathy, edema, all are absent except mild parallel. Investigation picture of this patient. CBC shows anemia, leukocytosis and PT-INR was raised, that means there was increased bleeding tendency. KFT report shows increase in urea, increase in creat and hypernatremia. LFT picture shows increase in bilirubin. There was serum transaminitis. Why? Because raised SGPT, SGOT levels, hypoalbuminemia and increased alkaline phosphatase level. Urine culture report shows Enterococcus species, which is budding yeast cell. Now HCV RNA PCR was detected. ABG picture shows respiratory alkalosis. Chest X-ray report shows heterogeneous opacity in the upper lobe on the right side and marked bronchovascular markings. Prolactin levels were raised, which were indicating septic shock. When we use the sepsis protocol to see if the septic shock is present or not, and yes, septic shock was present, I will tell you how we check it. First of all, we see that 2 SIRs should be present. Then we see, you have already seen that 2 SIRs is present, and in that we see general parameters such as temperature, your respiratory rate, your PCO2, your blood pressure and your pulse rate. Okay, now there were 3 present actually, है ना. Then sepsis देखते हैं. उसके बाद sepsis में we see that 2 SIR plus infection should be present. So TLC count is raised, that means infection is also present. So sepsis है. Severe sepsis देखने के लिए भी check कि लैक्टेट का लेवल बड़ा होना चाहिए, मोर देन 4 होना चाहिए. तो इस पेशेंट में लैक्टेट का लेवल 7 था. हाइपोटेंशन होना चाहिए तो उसका डायस्टोलिक ब्लड प्रेशर कम था, 55 था. एंड सेप्सिस कि वो दोनों रूल होने चाहिए. तो सिवियर सेप्सिस भी इस पेशेंट में है. सेप्टिक शॉक देखने के लिए हमें देखना है कि परसिस्टेंट सिवियर सेप्सिस होना चाहिए और साथ में MODS होना चाहिए, दैट इज़ AKI और डिरेंज्ड LFT, दोनों चीज़ें हैं इसमें. सो यह सेप्टिक शॉक है इस पेशेंट को. Ultrasound whole abdomen shows bilateral medical renal disease, moderate splenomegaly, gallbladder sludge, mild to moderate ascites. ECG report shows sinus tachycardia. Serum amylase and lipase level were within the normal limits, so ruled out pancreatitis. Dengue IgM was positive. So this patient ABG was showing type 1 respiratory failure. Okay, the diagnosis of this whole case is dengue fever, IgM positive with AKI, with ALI, that is acute liver injury, with septic shock, with HCV reactive and with COPD. Why COPD? Because उसका chest X-ray वैसी findings दिखा रहा था, support कर रहा था उसको. Second thing, there was triad, cough, sputum and shortness of breath, and another finding which was supporting COPD was type 1 respiratory failure findings. So I hope you have enjoyed listening to this case and I have added more knowledge to your brain. That's it. Dr. Muskaan is signing off now.